Hi there, my name is Corey Colson with Nursing 210, Professor Dowell's class through Liberty University. I'm here with Mary, my classmate and colleague and assistant today. We are here at the cardiac stress testing lab at Spotsylvania Regional Medical Center. I'm going to go ahead and do an initial scan here of the room just to show everything that's within our lab here. Of course, just kind of the standards. We have a treadmill and then medication area. This is all of our supplies. I'm going to be using the post-it notes to mark diaphragmatic excursions since Mary will have her shirt on. We have the gloves, Q-tip, measuring tape, tuning fork, smelling things, pen lights, reflex hammers, and of course our scopes and my stethoscope. So we will do a midway check for the room. This is of course our didactic 200-point video, so we're going to try and keep everything rolling. All right, ready to get started?
Yep.
Fantastic. So basically, we're going to be starting off first with the eyes, ears, nose, and throat, upper and lower extremities. And essentially what that boils down to is making sure that we don't repeat anything over our assessment. So we will essentially talk over a lot of the same points within our assessment later. Things like head and shoulder movement, carotid palpation, things like that. But of course, we'll be redundant in this sense just because of everything that we're covering on. So first, we're going to be looking at upper and lower extremities. Essentially, we can see that her color is pink to tan. The texture, of course, is normal to dry. Temperature is warm. Turgor you would assess basically by doing the tenting test here, and actually she seems to be a bit dehydrated, so maybe you need some fluids. We check for lesions on the upper and lower extremities. We check hair patterns. Of course, we see that Mary has normal hair patterns. I'm going to go ahead and check her hair on her scalp at this time too, and can see that that is all normal within a female hair pattern. She doesn't appear to have any varicosities. Her limbs are not edematous, so there's no alarming factors there. We're going to move to the nails. Of course, normally we would check for a cap refill. We can do that on the end of the nails. So you can see Mary does have some nail polish on today, but we can check just the end of the finger, and cap refill appears to be less than 3 seconds. They have good adherence to the nail beds on both hands, and we would check for clubbing. So we would do that basically by checking the angle within the fingernails, and everything appears to be normal with no clubbing. We would do this also for the feet as well. Mary has her socks on, not shoes, but I'm going to essentially defer that at this time to keep Mary's comfort since we are at work. We look back to the head, face, and scalp. So we check the hair pattern. We can palpate and inspect the scalp. Everything seems to be healthy. And of course, we mentioned that the hair pattern is normal for a female. Everything is symmetrical. The face is all symmetrical. Eyes, ears, nose, everything is midline. So we wouldn't be concerned with anything. And of course, we're going to touch on everything as we go from head to toe. We will start off by palpating the perinasal sinuses as well as the other sinuses within the face. So we're palpating, and there's no bogginess or crepitus within the sinuses. We can check the temporomandibular joint while I'm here. Have you open your mouth, shake your jaw back and forth. and there's no locking, pops, clicks, or any kind of crepidus within the TMJ. We can check the trigeminal nerve while we're here with our Q-tip. And essentially, we are going to cross the mandible with a hard and soft. That's your soft, that's your hard. So I'm going to go ahead and repeat, and you can let me know which is
hard.
which. Okay.
Soft. Soft.
Okay, great. And that was true. Hard, soft, and soft. So we can check the facial nerve, which is your cranial nerve number 7. We're going to have you smile, frown. Go ahead and raise your eyebrows, puff out your cheeks, show your teeth, clench real hard, open your eyes real wide, purse your lips. And if Mary didn't have her glasses on, I could have basically checked for resistance on her opening her eyes as well, but that's fine. We'll go ahead and skip through that. We are going to move down to the neck real quick and then bounce back up to the ears. So we will check the C-spine processes as well as the paravertebral muscles. I can feel the processes on the C-spine, and I can feel that the muscles here are actually pretty tense. If you can, go ahead and move your head back and back forward again. Okay. I'm going to, while I'm here, check the lymph nodes. So we can check the pre and post auricular, the occipital. We can move down to the submental, the submandibulary, maxillary, tonsillary, and of course supraclavicular nodes, right? Supraclavicular nodes. Okay. We are going to check the spinal accessory nerve by having you shrug your shoulders up high. Okay, go ahead and do that against resistance. And I'm going to have her do this later as well in our assessment. Go ahead and look side to side for me and touch your ear to your shoulder on both sides. Okay. And we'll check resistance as well here in a moment. We will move on to the eyebrows. We, of course, will start off with the hair like everything else. We can see that the eyebrows and the eyelashes, if you can look towards the camera there, are full and of normal pattern. They're brown in color. She doesn't have any kind of facial hair or anything like that. If that was the case, we would go ahead and notate that within our assessment. We can see that the conjunctiva is pink and that the sclera is white. We'll get a closer look on that with our scope here in a moment. We can basically palpate for the lacrimal sacs. I'll have her keep her glasses on, but you would do that basically by pushing on the sacs to check for tenderness. We can use the pen light at this time to look for pupil reactiveness. So I would dim the lights normally. We're not going to for time's sake, but I can do, it's kind of a low light environment, so I will do kind of a regular check here. Just going to hold the eyelid open and compare. And the pupils are equal, round, reactive to light, so they look good at this time. So at this time, they look good. Of course, we can also use our pen light to go ahead and check the ocular motor cranial nerve. So if you will, just go ahead and follow the pen light. We can do the 6 cardinal motions of gaze, right? We can go up. If you can, just go ahead and follow my light. So we'll go this way, and kind of this way again. Fantastic. She did move her head a little bit, but I think that was just accommodation, and her eyes were moving fine within the gaze there. We can check corneal light reflex, which I actually saw the red fleck when I was looking for the pupils, so that appears to be normal. You can do a cover and uncover test by essentially covering one eye, closing the other eye, and then quickly uncovering. somewhat, uh, somewhat of an uncovered test. And you can check for any erratic eye movements. She doesn't have any kind of nystagmus or any kind of deviation or laziness to the eyes. Everything is symmetrical. So great. We will move to the ears. We see that they are obviously symmetrical as well. We will first inspect. She doesn't have any kind of buildup or any visible issues. We will go ahead and palpate them. You can palpate all the areas here. Sorry. You can palpate the ears, and essentially what you're looking for is any kind of rebound, any kind of tension within the ears as well. So we can do the cranial nerve number 8 while we're here, the acoustic testing as far as the whisper test. And we've done this before, Mary. Essentially, I'm just going to have you close your eyes, and I'll whisper something in each ear. We'll just stick to a unilateral whisper test, but we'll assume that there are bilateral assessment here to save on a little bit of time. So go ahead and close your eyes.
Cardiac cath.
That's right. I said cardiac cath, and that would be positive for whisper test. Okay. We can do the Weber test as well as the Rhine test. Let me get my tuning fork here. And essentially, the Weber test is when we can check for bone conduction here. Can you still feel it? No?
Done.
Done? Already? Okay. And Rhine test, we can put it here. Still going? Yeah.
Yeah.
I hit that thing hard.
Yes, you did.
And we can check for, of course, air conduction. We know that air conduction is greater than bone conduction by 2 to 1. You should be able to hear. Can you hear it?
Mm-hmm.
Okay. Still? And then we'll just stop.
There you go.
Good? Okay. All right. We can move on to the nose, which of course will check for cranial nerve number 1, the olfactory nerve. Of course, as with any assessment, we're going to inspect first. We already palpated the sinuses, but I can inspect and make sure that everything is midline. I can assess the nares, make sure that the mucosa is moist and pink, and that she essentially, like I said, everything is midline. So let me go ahead and grab my pin light again here. And we'll want to just take a look. That appears to be so. You can check for patency. Just going to go ahead and help you occlude one nair and breathe in through your nose. You can breathe fine, and as well as the other way. Good. Okay. We can do the smell test, of course, to check for smell. I've got 2 different things here. I've got some shampoo as well as some body wash. Shampoo, body wash, as well as toothpaste. So we'll check both of these. So if you will just close your eyes, just going to give you kind of a puff or a wisp of one or the other. And you tell me what you smell.
Peppermint.
And what do you think that is?
Toothpaste.
Toothpaste, yeah.
Vanilla lotion.
Yep, that's correct. So I would assume that this is all within normal limits. The olfactory nerve is working great. So we can move on to the mouth and pharynx. Of course, again, we start off with inspection. So if you can open your mouth, I'm going to just take a look and make sure that everything is of normal color. It is, it's moist. I can check the frenulum by having her lift her tongue. Yep, good. And also, can you just go ahead and pull out your lower lip? I will take a look as well. Everything looks normal and intact. There's no lesions or any issues there. We can check while we're here the glossopharyngeal and the vagus nerve. Swallow and gag, we can of course defer on the vagus nerve but assume that it's working. We can check the uvula to see if it is midline. So if you will, just go ahead and say ah. You're going to want to move or look for essentially an up and down movement and midline placed uvula. So that's the goal, and everything seems to be normal. Her lips are pink and moist as well as the gums, like I had mentioned, and the teeth are in order. They're white and clean. Nice. Good job. And we will go ahead and check the, we kind of already did by having you move your tongue up, and we can check cranial nerve number 12, which of course is your hypoglossal nerve, and we can do that by more tongue movement. So go ahead and open your mouth again, stick your tongue out, move it side to side and up and down. Okay, and everything is normal. So that looks fine. Essentially, I'm going to go ahead and take this opportunity to do like my midway scanning of the room. I noticed that my essentially my last video I forgot to scan, so I'm going to go ahead and remember to do that today. So you can still see that there's obviously no one in here with us. And we are just getting away our work day. Good times. We did punch out for this. So it's documented, right? We did. We're good students as well as co-workers. Okay, so that of course wraps up what was our first video, and we will go ahead and move into what we covered in our second video, which is our lungs, cardiovascular system, and abdomen. So we're going to have you move around a little bit for this, as you know. So, of course, the lungs you want to inspect first. Basically, palpate. You know, there's only so much you can do within inspection and palpation of the lungs, but the auscultation and percussion are kind of an important piece here. So we will inspect the thoracic cavity. We can see that everything is normal and midline. You can see that the anterior and posterior are 2 times as great as the transverse, which, you know, obviously within your COPD or long-term barrel-chested patients, that wouldn't be the case, but that is not the case for Mary. The shape of the chest is normal. The color appears, from what I can see, to be normal as far as the rest of the body, and everything looks fine. If you can just breathe in and out for me, just look for symmetrical movement within the breathing, and that's normal as well. We're going to go ahead and palpate what we can within the upper portion of the thorax. You don't have any tenderness or issues, do you? Okay, great. We can palpate while we're at it. I'll go ahead and go behind you. We can check for the tactile fremitus by using the ulnar portions to check for resonance. So essentially you start off on the upper portions here. I'm going to have you say 99 every time you feel my hands on your back.
99, 99, 99, 99, 99.
Okay, that's good. While we're here, I can check for measurement of diaphragmatic excursion by getting my sticky notes and my measuring tape. I can do a little more palpation and percussion. So what we do is we have her breathe all the way in. We'll go ahead and percuss to find the diaphragm on inspiration. Breathe normal for a minute. Good. And take a big breath in and breathe all the way out. And hold it out. I'm going to percuss again. Good. And we can go ahead and mark these and check our measurement. Measurement should be within 3 to 5 centimeters. And yours is about right at 3. So, fantastic. We can, while we're here, percuss just generally in the lung fields, and we can auscultate. So I just had to grab my stethoscope. I'm gonna go ahead and percuss in the order. I'm gonna listen. Just breathe normal. We start on the top left apex here, move side to side. I can listen to the lateral lung fields. If you can, just lift your left arm up for me, all the way up over your head, and just breathe. All right, now the right. And of course, we can move to the anterior portion of the fields. And this is kind of a lateral auscultation as well. Excuse me. Just to point out, the stethoscope does have a drum and a bell. It's just digital. So we're going to utilize both. Okay, cardiovascular, we will inspect, we will palpate, and then we will auscultate. As far as percussion, there is nothing to percuss in this assessment. So inspect first, of course, for any kind of heaves, lifts, thrusts. We can go ahead and palpate the area. Essentially what we're doing here more than anything is we've already checked the thoracic cavity, so we're going to check for the point of maximum impulse, which is at the fifth intercostal left midclavicular space, also where the apex is. So we've kind of put a visual marker on that to go ahead and get started. Of course, we know our kind of big points, as mentioned before, are the aortic, pulmonic, tricuspid, mitral, and then Erb's point, which is APT, IM, essentially, or mid-sternal border, and then Erb's point is your E. And that's 2, 2, 5, 2, 2, 3, 4, and 5. So we'll go over those a little bit more. So second, right intercostal midclavicular would be your aortic. Pulmonic, of course, would be the left second intercostal. You can move down to the third and fourth for the sternal border and Erb's point, and then of course the fifth will take you all the way down, as we've mentioned, to the apex, and we already palpated that, but we can go ahead and give all of those points a listen. And of course we know that the S1 is heard best over the tricuspid, I'm sorry, yeah, S1 is heard best over tricuspid valve and mitral valve. The S2 is heard best over the pulmonic and the aortic valve, and the S1, S2 are heard evenly over Erb's point. So we're going to go ahead and listen for those. So I'm going to go ahead and switch. And my stethoscope will tell you, I think this is one thing that we've forgotten for our basic vitals, a blood pressure cuff, but I'm sure we can dig one up. Stethoscope will tell me that there's an even heart rate of 65, so it does give me a rate. So, aren't I fancy? So now that we're done with our cardiovascular assessment, we will move on to the abdominal assessment. But before I lay you down, I just want to point out within our pulse checks that I could check the femoral pulse once I lay her down, but I'm going to go ahead and, of course, defer that. So we're going to move from the pulses. I'm going to start off in the brachial here. I can feel a nice brachial pulse. Radial. I could hear over the aorta while I was there as well. I will check the post tibias and the dorsalis pedis while I'm here, but like I said, I'm going to go ahead and skip the femoral, and those all feel great. Okay, and then actually you do have some bounding EPs. Okay, so I'm going to check one other, just the carotid. Of course, when you're palpating for the carotid pulses, you want to do one at a time so your patient doesn't pass out. And I forgot to do this during the neck, so I'm going to go ahead and do it now. Checking for any kind of bruise. I can hear tracheal air movement. And you can also, if you feel like you have an enlarged thyroid, you can auscultate for the thyroid, which is something I mentioned or didn't mention at first, to check for any kind of vascularity within the thyroid or any kind of bruises as well while you're up there. So since we went ahead and checked all the appropriate pulses, we're going to have her lay back. And this is when I could check for a good femoral pulse, but I won't. I'm going to lay you down all the way. Our assessment here is a little bit different, just because if you have a patient with any kind of intra-abdominal issues, of course you wouldn't want to just start poking around. So we're going to inspect and auscultate before percussing and palpating. So you just have to kind of remember that as you go. So we would inspect with the shirt up. Mary's a mother of a few, so I would assume there might be a little bit of striae there. Maybe not, perhaps not. We would check for vascularity, any kind of patterns. Everything is symmetrical and midline. So that's part of our basic inspection before we go ahead and start pushing around. I would ask about hernias. At this point, have you ever had any hernias, umbilical horn hernias, inguinal hernias, anything like that? Okay. I don't see that the belly is pulsating. Of course, we'd be worried about any kind of aortic aneurysms within our assessment. We would check for masses and things like that. So I'm going to go ahead and auscultate. First, with the bell. Check all 4 quadrants. You can check for vascularity within your vascular organs. See if there's any kind of whooshing or blowing sounds. And sometimes with superficial arteries you can check for aortic, iliac splitting, renal arteries, anything like that. Of course, I can do that with a push of a button. And everything appears to be normal. You know, I totally just realized as we're going on, I didn't look in your ears at all. So I'm gonna look in her ears. It just dawned on me as soon as I was thinking about all my scopes. I'm going to look closer in her ears and eyes because we don't want to miss anything today. So rather than starting all over again, we're going to do that. Okay?
Okay.
All right. Fantastic. So you can lay back down. We'll finish this assessment first, and then I'll get you once we set you back up. Almost forget that. So we are going to percuss. So we've inspected, we've auscultated. We're going to go ahead and percuss. Essentially, you're looking for tympany or dullness. You can hear the change over the stomach, which is in the left upper quadrant. To the liver, there's definitely a big change because the liver would show a dull, resonant change, and then of course the stomach would be empty and give nice tympany. So you can also find the liver, the borders of the liver while we're here doing this, and we can measure that. I'm pretty good at measuring livers. You can usually feel the edge of the liver as well. I'm going to go ahead and palpate a little bit because I know that she's had no complaints. Everything sounded fine. You know, for a living, essentially, we look at organs underneath X-ray. So I can tell you that the normal liver is between about 6 and 12 centimeters, and hers is within normal size, which would indicate no hepatomegaly. The spleen is not palpable, so I'm not even going to try. The kidneys sometimes are palpable. There is a motion that you can use essentially when you put your hand underneath the flank area and the other hand on top of the belly, and essentially you know, breathe in and out and try and feel the borders of the kidneys. I'm not going to attempt it, but there is a way to do that, and you can do that bilaterally. And of course, the kidneys in everybody are a little bit different. Everyone's anatomy is, of course, a little bit different. So that's essentially, I think, our abdominal assessment seems to be right. Okay, so go ahead and sit on up for me again. Hope I didn't miss anything there. It threw me off the fact that I was looking at my scopes and realized that I didn't look in the ears. So I was too busy talking about feeling the ears and what I was looking for there and palpating that I didn't do a thorough inspection. So, sorry. Alright, so first we're going to go ahead and put our cover on. We can look in the ear and see, I can actually see the tympanic membrane, which is a nice bluish gray color. And we can see the cone of light, which on the right ear should be about 4 or 5 o'clock, and then on the left ear around 7 or 8 o'clock. And I looked with the pen light. I did not a real corneal check on the eye. And I can actually see the corneal reflex, the light reflex, as Mary says, the twinkle in your eye. Of course, the most important part of the eye assessment, and we almost missed it. Okay. I'm not going to look at Mary for anything because I need to do a checklist in my head here. Just make sure we're good. No, it's no help. I think we're good to move on. Okay?
Mm-hmm.
What's done is done.
What's done is done.
What's done is done. All right, so we will do our musculoskeletal and neuro assessment. Okay. So within our musculoskeletal assessment, essentially the way I try and remember this is essentially starting at the top, moving down and checking, you know, flexion, extension, abduction, and adduction on each extremity, as well as the midline of the body. So we can start off basically by doing the hip. So we can, sorry to sit you up, we'll lay you back down real quick. And we'll check your hip out. Okay, so you can start with flexion by lifting the leg straight up. Okay, extension by putting it straight down. You can do abduction, which I always like to remember, like I was taught in A&P, like aliens, you put your arms out for abduction, so you can put things out. So we're going to go ahead and push out, and then adduction would be crossing the other leg and over, okay? So we're going to do all of that again with all of our assessment against resistance. So go ahead and lift your leg, put it back down, okay? And then push against me for abduction, and then adduction would be across the other way. So go ahead and lift across, good. We can check the knee while we're here. So go ahead, rather than lifting the leg straight, go ahead, yep, lift. And then put it back down for extension, and then against resistance, lift the knee, good, and then back down, good. Part of the hip assessment, you can check for external and internal rotation of the hip, so you can bend the knee again, and you want to kind of throw it right over the body, and then you can kind of flip it out for external like this. So So we're going to do that again, but against my resistance. So go ahead and push the knee kind of up, adduct across your body for internal rotation, and then external rotation. Whereas if you're sitting, it would be kind of like sitting like on a saddle or like a man. We can remember it that way. We check for the feet. So we check for plantar flexion and extension. So go ahead and push your foot down, and then of course dorsal checks up. Yep. And then internal and external rotation in and out. We can check the toes. Push your toes down. Go ahead and flex them back out. Spread them apart, and then kind of smoosh them together. Okay, so of course, again, we're checking for flexion, extension, abduction, and adduction as well. Within the feet, that dorsal flexion is when you're pointing your toes up. And then, of course, you want to check full rotation of the ankle. So I can see that that is all good. So we're going to check against resistance. So go ahead and push up, internal, external. Let's try just the toes. Back, spread the toes, and then put them back together. All right, and then rotate the ankle. Good. And I would check this bilaterally. We would do the right as well as the left. So we will have you go ahead and stand up. If you want to get up on this side, I'm just going to move the bed out of the way a little bit. Pretty easy, right?
Mm-hmm.
All right, we can do a hyperextension of the hip. So we're going to turn her this way and basically have you kick your foot out while balancing on one foot and go out backwards towards me. Stick your foot out towards me. There you go. So that is kind of a hyperextension of the hip. I'm going to check it against resistance. So go ahead and push against with your calf. Good. It's actually strong, and she has good balance, which we're going to check here in our neurologic assessment as well. While she's standing, we can check the neck. So go ahead and come this way, or straight towards the camera. Sorry. We will do flexion forward. So go ahead and push forward. And I'm just going to have her go ahead and do it against the resistance, as well as kind of a free movement, but go ahead and push. Okay, and then you can try for extension backwards, and then hyperextension kind of all the way back. So go ahead and push all the way back. Okay. Let's have you push against my hand this way. And this way. Okay, good. So there, of course, we did our spinal accessory earlier and checked for the same things, but we want to be sure that the rotation as well as the lateral bending are all good, solid range of motion. Of course, I had you push against my hand, but I'll have you look side to side as well. So look far left and look far right. Good. And then I'm going to just do the resistance again. Look far right. Right. Yep. Look far left. Okay, good. And then we can start kind of moving down the arms from here. We will do the shoulders. So you can shrug your shoulders up. And I'm feeling that the resistance there is good. Rotate and roll the shoulders back. Good, good, good. We can check for extension. So you can kind of just slightly bend down at your side, on both sides. Try the other side. Good. Of course, we talked about our abduction. So arms out and up like this. And then adduction would be kind of crossing your arms like so. Good. Fantastic. External rotation essentially would be like when your arms go up like this. All right. To just leave you there for a minute. And then we can do internal rotation by essentially moving the shoulders back down this way. So I'm going to have you do that and push against my arms. So go back up for a second. Good. And then back down. I'm going to kind of push against your triceps. Good. So she is strong. There's no muscular deficits anywhere at all. We can go ahead and move down towards the elbows. While I'm doing that, I can look at the flexion of the bicep. So go ahead and flex up. Yep, good. And down. Good. So that's your flexion and your extension. And I went ahead and checked resistance for both. We can do the supination, which again is kind of just hands up, and then the pronation, which would be kind of hands down as well, with the elbow checks. We kind of already did all of that, of course, when you were shoulders, hands, knees, and toes. So we can move down to the next joint, which would be the wrist. So go ahead and flex against my hand, and then extend. Internally rotate your wrist. Go ahead and put them out like this. And then external rotation. We can move down to the fingers, kind of like the toes. Going to have you push down, and then extend up. Good. We can have you abduct out. I'm going to hold the fingers like this. Abduct out. So spread your fingers. Yep. And then I can put my fingers in hers and feel the adduction, which is the inner movement of the fingers, like so. So pretty easy. Basically, if you just move to the end of the extremity. We can do the thorax now. So we'll go from head to toe. So we'll have you bend down. We'll check your range of motion, try and touch your toes. I'm just going to check here for any kind of scoliosis and back straightness, any kind of tenderness within your back.
No.
Do you have any, you can stand up. Do you have any deficits at all?
No.
Okay. So I'm going to stand behind her and have her kind of lean over, try and touch her toes again. I'm just going to check core strength, and then go ahead and bend down, touch your toes, and lean up. Okay. And I'm checking strength on both sides with resistance, and everything looks good within the flexion and extension. You can hyperextend like this, and just kind of lean your shoulders back, but keep your hips normal. So lean, 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 lean. Okay. And do it again one more time. Lean, lean, lean. Good. Awesome. So the hyperextension range of motion is good as well. We can check for rotation. So I'm going to have you look straight at the camera and do a little twist like this. Yep. So the rotation looks good. So we also, within the joints during all of this, of course we're inspecting. We notice that there's no discoloration. You would palpate as well within the joints of the elbow, the shoulders, the wrists, even down to the knuckles to check for any swelling, redness, heat, any kind of issues at all that she might have, which she doesn't. So we can go ahead and move to the neuro assessment. I just need to get the rest of my stuff together here. We can start by doing the heel to toe gait, so I'm going to have you move like all the way. Let's see what we can see here. Move the bed. Okay, just come back to the wall. You can't really see her toes, but I'm going to do a heel to toe gait, which is essentially putting the heel against the front toe and walking in a straight line forward. And that looks good. We could do the Romberg sign, which is when you stand there with your eyes closed, and I'm going to give you a gentle push. Okay. Essentially, she's responding well to that. She's not being kind of pushed off of her axis or falling over, so obviously her balance is good. You can check upper extremity and lower extremity movement. I'm going to have you put your hands on your quads, and you can flip them from palm to surface kind of rapidly, and we'll check the heel to shin movement. You're good. You can go ahead and slide your heel down your shin on both sides, and I can see that she can stand while she's doing this on one foot, so we would check for balance there too. Go ahead and close your eyes for me. You're going to move your fingers straight out, arms straight out. Sorry, this way. We're going to do finger to nose, okay? So go ahead and keep your eyes closed, finger to nose, other finger to nose. And of course we know that this is also sobriety test and that she's not drunk. So she looks good. We can do the stereognosis check, which is essentially we're going to put an object in the patient's hand while they're asleep, while they have their eyes closed. I'm almost asleep. While they have their eyes closed, and have them identify it. And what I'll do is I'll actually grab a couple objects while you've got your eyes closed to see how well she actually does.
Okay.
So you can try this one first. Go ahead and put your hand out.
Gum.
It is gum.
Highlight.
Yep. Did you cheat?
No.
All right, good.
No cheating.
We can check the gravisthesia, which is where we can kind of write something on her. You can do it in like the palm or the back. So close your eyes. I'm just going to put a letter here, okay?
T.
Yep. And you can do it on the back as well. Make sure they're really not cheating.
F.
F, yeah. That's true. T and F. Essentially, we can do. We didn't bring our tongue blade, did we? We decided we can do light and soft, I guess, with the Q-tip. So we can do a light and soft touch here with the Q-tip. Go ahead and close your eyes, and you can do that.
Hard. Soft. Hard.
Of course, she's got clothes on, so it's kind of hard, but.
Hard. Soft.
Okay. I don't think it would be uncommon. She said hard for a soft area, but this is kind of a hard surface as well. On the chest, I'm sorry. That was kind of my bad. So we can check for vibration sense. Since I'm back to work and I can actually use this and not a child's toy. Let's see how this works. So essentially I can do this on the bony prominences of the area. So we can do it, actually go ahead and sit. See if we can still see you, right? As long as we can see you, I think we're good. All right, so you just tell me when the vibration starts and when it stops. So go ahead and close your eyes.
Stop.
Yep. Okay. And you can do this on the hand, so go ahead and hold your hand out. Still
Stop.
Still
Yeah.
going.
Yeah, that was a good one.
Of course, we can check reflexes as well, and essentially, because we've done our tuning fork, I won't use that. I used on Megan in my stethoscope, so I'll actually be nice and use a reflex anyway. So we will do, first we can check the bicep, for the tendon reflexes, bicep reflex. Go ahead and let it hang. And of course, as in the instructional portion of our test here, you can have them look away. I know she can still see me in the video, so she knows I'm going to hit her. There, and we actually got a good positive tendon reflex. The line here, I have a hard time kind of hitting the tendon. I got you there. Of course, we can check the tricep. So we're going to kind of hang the arm. Have you not know when it's coming? So I think we actually got you there. Did we get you? Okay, good. And then, of course, we can check the knee, the patellar, deep tendon here. That way for a second. And we did have a good response there. And then, of course, the Achilles. So what we would do, to be honest, is have you stand up, have you put your hands and knees on the bed, and elevate your feet. Go ahead, kind of like on all fours, get your knees up on the bed. Yep, kind of an awkward little deep tendon here, and I actually had a good positive response, so you can go ahead and stand. All right, great. So I don't think, I'm sure there's some things that we missed here, of course, but it is what it is. So Mary's been a very good sport. We're going to do a final scan. I try to do kind of a mid-scan on everything. I think we used all of our tools. Having the tools, I didn't use any gloves, of course. Proper hand hygiene, I guess, is a better option. You can still see nobody's here with us. We've got the phone, which amazingly has not rung. And that's that. So I appreciate it. It's been a great semester, and we thank you for your time.